Yeah, good evening all. At the outset, I would like to thank Dr. Viraj, Dr. Shivam, and the entire team of Shalby Cancer Hospital. And I welcome all the panelists. Uh, we have sort of a multidisciplinary tumor board with three surgical oncologists, one medical oncologist, three medical oncologists rather, one radiation oncologist, one nuclear medicine physicist, and plastic and reconstructive surgeon. So welcome all on the panel. So our job here is like this gentleman. We have to finish our quota in 30 minutes. This is what the management has told us. And I would keep it simple like how he keeps simple. I would like you all to be very crisp, to the point, and you all should not repeat the answers which your colleagues have already told, so that we'll be able to finish all the 3 or 4 cases which I have on the panel. Uh, what I have done is I have just taken the liberty to change it from early operable to resectable. In the interest of time, what I have done is we'll take the surveillance part, the imaging part, the salvage surgery concerns and counseling before we go on to the cases, so that we don't discuss all these general points when we discuss our cases. So when we come to the post-treatment surveillance, surgeons can take this thing. The post-treatment surveillance, which is the imaging modality which you all will do.
For post-treatment surveillance, I prefer PET-CT scan after 3 months of the completing definitive therapy.
Okay, so all agree to this. So NCCN also says PET-CT may be the most sensitive imaging modality, and one article by Dr. Abhishek Mahajan says post-surgery PET-CT, and on follow-up also a PET-CT is important. So we don't have any other discussion on this. Now if we see the nuclear medicine guidelines, we have a nuclear medicine physicist. Can you just comment on this? This is from the Journal of Nuclear Medicine, and it says yearly PET-CT for surveillance to pick up early and operable recurrences.
So the guideline says we do have to do PET-CT after the after the post-treatment completion, that is after 3 or 6 months. Then up to 1 year, okay, we can do. But after 1 year, whenever the patient come for the follow-up, the many papers and even SNMI says you have to do PET-CT only if the patient is symptomatic.
Okay. So the thing is, point well taken. If a post-treatment PET-CT at 3 months is negative, there is no data to support substantial benefit of any further imaging in an asymptomatic patients with a negative clinical exam. Currently, there is no prospective randomized trial showing that systemic post-treatment surveillance imaging of patients with treated head and neck cancer, it is beneficial in terms of survival also. So I think we all agree on this. One PET-CT at the completion of treatment after 3 months, and then only if the patient is symptomatic. One more imaging thing which we do routinely is image guided procedures. So if we have a patient who has got a lung nodule, we have to biopsy it. In this case, the biopsy turned out to be non-malignant, so there was no malignancy. So this again is a very important thing, both for the primary lesion also and for a solitary lung nodule also. So this also we routinely do. Now we come to the salvage surgery. So surgeons can take this. What are your major concerns when you deal with a patient with a recurrent oral cancer? Surgeons, please.
First, we have to see the earlier stages, primary what was the stage of first disease, and then disease-free survival is also important, whether any adjuvant treatment taken or not. And
Okay. Any additions other than this? So what we did is we also looked at our survival and clinical outcomes after salvage surgery. So what we found is early recurrences with a disease-free interval which is less than 2 years, the survival outcomes were very poor, the overall survival, and patients who presented with late recurrences, the outcomes were better. The other most important thing is whether the patient has received adjuvant treatment during the first surgery or not. That also is a very important thing, and it also affects your overall survival. The recurrent disease, the stage is important. The most important concern is the margin of resection and the reconstruction. If you see in our paper also, almost 20% of our patients had positive margin, even after selecting our cases well. And most of these patients will have stages which are advanced stages. So early recurrences are rare. We have seen most of the patients presenting with advanced recurrent cancers where a margin positivity is also a concern. Reconstruction options are also very important when we look at advanced recurrent oral cancer. Patient factor performance status is important. Apart from these things which are listed here, any other point you all want to make? Anyone?
As a reconstruction point of view, we had also see what reconstruction was done in the past,
Very
and
true.
the possibility of the second options, whether available
Yes.
neck vessels, what is the space, what is the
Correct.
how is the skin condition and other things.
Correct.
What are the options that we can offer?
We have one case, during our discussion, and we'll take this thing during that. Again, counseling also plays a very important role, and in our multidisciplinary tumor board, we discuss about the outcomes which we all have seen in our paper. If you see, we analyze 82 patients. At the end of 1 year, 20 patients died because of disease, and at the end of 3 years, only 25 were alive. So this again is very important. The other important thing which I always discuss with my patient is the willingness of the patient to complete the full prescribed treatment. Because if you see in our patients, almost 80% of the patients would require some form of adjuvant treatment. So it is very important to counsel them. They have to finish this prescribed treatment, otherwise the outcomes will be very poor. Even after doing everything, you can see 5 of our patients defaulted their adjuvant treatment. So again, this thing is very important. One important thing is in literature, you have this prognostic scoring system. If you see, you can read these papers. Any one of you in your multidisciplinary tumor board uses this prognostic scoring system for decision making before you do or you treat these patients. Any one of you are using this? No. So this is well mentioned in the literature, but nobody in clinical practice is using it. So now we will come to our clinical cases. This is our first patient who is a recurrent squamous cell carcinoma, a T3N1M0. The patient had undergone a left-sided buccal mucosa wide excision, segmental mandibulectomy, upper neck dissection, and a anterolateral thigh flap. And now he has recurred the same side, the left palate, and you can see the lesion. The patient is RT naive, and the disease-free interval is around 10 years. So what next? The imaging also I'll show. This is the PET-CT image of the same patient showing the local recurrence plus an ipsilateral low level 4 node also which is visible. So now the surgical plan, the surgeons. I don't think the medical oncologists and radiation oncologists have to have any suggestions. The patient is operable, so the surgeons can take this. So the surgical plan, be very specific, and the pointers which I have mentioned, you have to tell us the complete whether you are going to address the neck, and the reconstruction the plastic surgeon can take. So surgeons first, the plan, surgical plan.
In a surgical plan, we will go for an infrastructure maxillectomy with completion neck dissection on ipsilateral and also contralateral neck dissection.
Okay, you want to add, Bhavin? If you want to add anything, then add,
I
or
would-
else,
No, I would add reconstruction.
yeah,
part.
reconstruction he can take, yeah. Please.
First thing is, after the resection, I would like to evaluate the type, how the vessels are of the neck, whether they're post sync. Usually 10 years is a good time, mostly.
No, but the reconstruction plan has to be told to the patient before the surgery.
Usually what we do is I always tell them that even though our primary plan would be a local flap in this case, since he has got a good thing, I think good local plan would be a superiorly based nasolabial, or of course you can go for temporal, which is not my very preferred thing. A free flap is a good option in this case, provided the neck vessels are good.
Okay.
Yes.
Okay, point well taken. Now, my point is why you want to address the contralateral neck?
Because ipsilateral side has been done before 10 years, and usually when ipsilateral neck dissection has been done, because of a new primary or recurrence, there will be alteration in a lymphatic channel and it can spread to contralateral neck. That's why I would like to address contralateral neck.
Okay, anyone wants to add this?
Normal lymphatics is already violated, so we have to go for
Okay, so we also looked into our incidence of contralateral neck, patients presenting with a recurrent oral cancer, a ipsilateral recurrent oral cancer, and we found out two things which predicted the contralateral nodal metastasis: a pathological neck node positivity and margin status during the previous surgery, and radiotherapy naive patients post first surgery showed a higher incidence of nodal neck recurrences. And the histopathological features of the second surgery or the salvage surgery, the depth of invasion and ipsilateral nodal positivity with extranodal extension were important factors why we address the contralateral neck. So depth of invasion more than 1 centimeter, the chances of contralateral neck in the contralateral neck are around 80% in our study. So this is what why we do a contralateral and ipsilateral neck clearances. So the patient, what we did was we did wide local excision, infrastructure maxillectomy, and both sided neck dissection and a radial artery forearm flap in this patient. This is the histopath report. The radiation oncologist can just briefly tell us about the adjuvant treatment.
So because it is PT4AN0, we would definitely like to address it with radiation. So the local site and the ipsilateral neck, both we would like to address because it is an RT naive patient and it is T4. So the same neck and the local area, both will be addressed.
Great.
Yes.
So everyone agrees to the plan. So the patient went for adjuvant radiotherapy, and he is about to complete the radiotherapy. So now we move on to the next case. So this is a patient who presented with a right-sided neck node. So it's a recurrent lateral tongue squamous cancer, operated for a primary 3.5 years before. Again, the primary was, it was a T1 tumor. So the patient is a radiotherapy naive patient. If you see the imaging, the PET CT, the primary is well controlled. There is a neck node at the level of right level 2 to 4, and they have mentioned the right IJV, anteriorly the angle of contact with the IJV is 90 degree, and the common carotid and ICA is abutted with the angle of contact of more than 90 degree. So now before we move on to the treatment plan, any other imaging which surgeons would like to have? Any additional imaging before you go in and operate this patient?
Sir, I would like to add, I would like to know more information in this PET scan. If it is mentioned there is involvement of paraspinal muscles whether it will be involving prevertebral fascia or not. And one more point for additional imaging is if angle of arc of contact is more than 90 degree, and I would like to do balloon and angiography of the carotid, if at all we are planning resection.
So the general teaching is if the contact is less than 90, it is operable. You know.
Yeah.
But we always do a additional, just a Doppler of the neck, just to be very sure whether the internal, see our concern is mainly the internal carotid. You know, so that is something which is very important, because that is something which we have to get the upper stump if something happens. So that is our concern. So here you can see we did a Doppler of the neck, and it matches with the PET CT images or the CT images. So we did a right-sided neck dissection followed by adjuvant CTRT. Now one question to the radiation oncologist is the field of radiation in this patient. The patient was operated left side tongue wide excision with left-sided supraomoid neck dissection, and now a right-sided modified neck dissection.
So, in all cases of tongue, we address both the necks in radiation, and even in this patient, I would like to go with irradiating the primary and the bilateral neck. Both.
Okay.
Yes.
Okay. So this is very important, the field of radiation. Now just to have the discussion further on this, if the angle of contact to the ICA was more than 270 degrees, then what are the treatment options? Surgeons first, and then we can go down.
We can go for balloon occlusion test and carotid resection.
So you will still operate the patient. Everyone agrees.
Second option, we can go for NSCT.
No. You tell me your this thing, whether you
I will go for NSCT.
You will go for NSCT. Bhavin?
I believe ICA more than 270 is unresectable disease.
Okay.
So won't operate.
So tell me one thing, CTRT upfront or NSCT?
CTRT upfront.
No, let them now take the...
No, I would not like to go with CTRT upfront
Why?
because it
Why?
doesn't look curable with radiation alone. So I think I would like to downstage it with NACT first, and then would like to go
So
for
what do you
anti-PCT.
mean by downstage?
So basically, this much bulky node, it is difficult to remove it with radiation alone, like along with the help of chemo, but directly giving primary radiation doesn't make much sense to me.
So now the medical oncologist.
Even I would prefer NACT first, because that would also tell us the prognostication point of view.
Correct.
So NACT, and then I'll take a call.
So NSCT, what is your experience for neck nodes?
Doesn't respond much.
So what I have experienced is the neck node, the size of the node goes down, but the contact, it doesn't go. So if you are thinking of operating this patient, giving NSCT, it is something which the patient will never come to you for surgery, because the area of contact will never change. The size of the node will decrease, because NSCT for neck nodes, I have not seen good results. It doesn't give you results as it gives for the primary in some cases. Cycles, NSCT, after how many cycles you will assess?
I'll assess after 2 cycles.
2 cycles of TPF. Okay. So NACT followed by assessment, and then if there is a response, CTRT followed by salvage surgery if there is a disease. Okay, so that is the plan. But this is just a hypothetical situation which I have put. Okay, we move on to the third case. So this patient is a right-sided posterior tongue squamous cancer, T3N0M0. The patient was operated for a lateral tongue lesion. It was T1, depth was 2 mm, neck was observed, and now she has got this posterior tongue lesion. Disease-free interval is just 8 months, less than 8 months. We did a EUA on this patient. Posterior tongue is involved, TL junction is involved. Induration is reaching the base of the tongue, the floor of the mouth, and it is crossing midline. This is the imaging, the PET CT of the same patient. So surgeons, first tell me whether it is resectable or it is not resectable.
It is resectable.
Resectable.
I'll go with NSCT.
You will resect.
I will go with NSCT.
So it is resectable, but you will go with NSCT. Why?
Because reconstruction will be difficult and morbidity will be more.
Reconstruction he'll be able to do. It is
Post-op
difficult.
morbidity will be very difficult.
No, reconstruction is difficult.
No, not in this.
It is not difficult.
Morbidity will be more.
Morbidity.
More.
What sort of morbidity?
In that swallowing and
Swallowing and speech. Margins you are worried? No. So the base tongue is involved. Your margin, posterior margin will be,
still there is a space.
there is space. Okay, so you will go for NSCT. Bhavin,
Yeah, I will go for NACT.
you are not speaking anything.
I am medical
You are
oncologist.
medical oncologist. Okay, so then he will go for NSCT. Bhavin also. So NSCT.
Yes,
So 3 versus 2 drug, 2 versus 3 cycle.
3 drug combination TPF
3
for
drug.
2 cycles followed by assessment.
Okay, all agree on this? So we also did the same thing, NSCT, but we did 3 drugs and 3 cycles. So we repeated a oral cavity contrast enhanced MRI with a CT chest. And this is the MRI picture of the same patient after 3 cycles of chemotherapy, TPF. So now surgery or CTRT. Bhavin, surgeons please.
I would like to offer a surgery.
Surgery.
Yeah.
So your post NSCT margins or pre NSCT what?
So I always take pre-NACT margin as because there are not enough data.
So then the same morbidity and everything which he
Yeah,
was talking.
but I would like to add that I prefer NACT in tongue because of bad tumor biology.
But
Because of in this particular case, DFI was also less. That's why.
so you will, your decision will be DFI and the biology. The
Yeah,
tongue.
yeah.
Okay. So
If 30% of the base of tongue has been preserved, then after adequate swallowing rehab, patient can achieve good swallowing after free reconstructions.
So in tongue lesions, our main thing is to give maximum functional outcome. So I always prefer to do a post NSCT margin
Okay.
rather than a pre NSCT margin. But yes, it differs. There is no literature
Yeah.
which says that this is better than this.
Yeah.
Okay, so we did a composite resection with a ALT flap. Okay, and it was T3 N3B, and the patient received adjuvant CTRT. So you all agree with this treatment plan? No? Okay. Now the fourth case is a recurrent upper lip cancer, T1N0M0 left upper lip. The patient was operated first time in 21, wide excision with marginal mandibulectomy with upper neck dissection with radial artery forearm flap. Then he had a hyperkeratotic mucosa on the left angle of mouth which was excised. It was no malignancy. Then again the patient recurred, left lower GBS, squamous cancer, wide excision, segmental mandibulectomy, right side opposite, that is contralateral SOHD, free fibula with adjuvant radiotherapy was given. Now the patient develops this thing and the disease-free interval again is less than 1 year and radiotherapy also less than 1 year. Treatment plan. Imaging is all operable. Surgery. All agree. Surgery. So we did a upper lip wide excision with a nasolabial flap. You will do something different.
It depends on the neck, sir. How
Neck was good.
if the neck was good, we can still go for
But I
another.
tell you, the neck was good means that it was a vessel depleted neck in the sense the left side vessels were used for the
Radial
radial
flow.
artery and the left side was used for the free fibula.
But still we have the
Still we
ECA
have,
and the
but you will, but we
it
did
could be kept as an option. I would not say that.
So we did a nasolabial because this was something which was.
What we generally do is we explore the vessel and just look at how the
Correct.
ECA is. If the ECA feels woody, then
Okay.
we generally go for a local flap.
Okay, agreed. So the histopath is showing moderately differentiated squamous cancer, 5 millimeter, depth is 3 millimeter, lateral margin is 4 millimeter, base is 3 millimeter. So the margins are so-called compromised. No lymphovascular or perineural invasion. Adjuvant treatment.
As far as radiation is concerned, it has already been given before 1 year, and it's on the same side, that is on the left side. And looking at the size of the tumor, the depth of invasion, I think even if the margins are less, I would still like to observe.
Okay, observe. All agree to this. We also are observing this patient.
But one thing I would like to add is from the radiation part we can observe, but I think we should consider this patient for some oral metronomic therapy because it is recurring since last 4-5 years.
Please answer this.
Yeah.
Both.
So, So that OMCT data was negative on TMS trial was there and it doesn't show any OS or PFS benefit. So I would not like to add any adjuvant treatment.
Correct. So we are also not doing anything. We are just observing the patient. No adjuvant radiotherapy, no chemotherapy also. Any experience with these agents, immunomodulators, they have shown results and people have tried, surgeons have tried this thing in oral pre-malignant lesions. But any experience in recurrent cases like this? Any one of you have?
So, yeah, I would say I don't have data, but I was part of DMG for this role of curcumin in SPT trial, SPT, secondary primary tumor.
Yeah, that I have. We have got the highest number of cases.
Yeah.
So curcumin and metformin thing,
Yeah.
we have the highest number pan India, 180 plus I think cases. So that we have, but that is for early squamous cancer, not for recurrent cases. This is something which is very specific. If you all have any experience using these drugs for recurrent cases. Now the last thing is oligometastasis. Can anyone of you define oligometastasis? It is there. So it is defined as a cancer which is, usually characterized by less than 5 clinically detectable lesions. There are various synchronous, metachronous, which is also known as oligorecurrence. We'll not go in detail. Now, if this patient, the slide which I had put up first, has this nodule came positive for squamous cancer, what are the options? Any of these cases which we have discussed previously, with this single nodule coming positive. Options, please. Surgeons.
Solitary nodules, or if metastectomy is possible, it can be done.
So there is literature available which says you can operate in a solitary lung nodule specifically in any of these situations. So either you do a metastatectomy, or they would do a stereotactic radiotherapy or systemic therapy. Any role of systemic therapy in a single nodule?
Actually, there is no data for that, but I think we should add systemic therapy with radiation because it is already metastatic. So chances of recurrence is very high.
Okay, so the factors are the number of lesion, lung metastasis, disease-free interval, and age and comorbidities. So I'll conclude my this thing. The timeline for first post-treatment surveillance is 3 months. NCCN says 3 to 6 months. Salvage surgery is the best option with good survival outcomes. Completion of the ipsilateral neck and addressing the contralateral neck, even for clinically node negative, is recommended. MDT for decision making and to improve the functional outcome is very important. And there is emerging data on curative intent of oligometastasis with lung nodule. However, the practice will vary across the globe. So, thank you all for